have seen probably already in the chat that there are so many questions, and these questions are so good questions because this is very important question for our clinical interpretation of the patient situation and also the management of the patients. And I think we just go ahead and start with these questions, and we will try to answer them all. But of course, if not, we will try to answer some of them at the end of the webinar. But if not, so we have to say sorry for that because they are really good questions. So let's start. And I think Maya, I want to start with you. So first you talked about ectopic pregnancies and you talked about on ultrasound diagnosis of ectopic pregnancies. So my question to you is to operate on a suspected ectopic pregnancy based on ultrasound clinical symptoms, which patients should we schedule for laparoscopy if we suspect ectopic pregnancy and not necessarily have ultrasound findings confirming it?
Well, normally I wouldn't do any treatment until you've completely confirmed the diagnosis. That's really, really important. The only person or group patient that you might take to theatre for surgery is the patient and you're not clear as to the location of the pregnancy. So you've scanned them, you've seen an empty uterus throughout, is where you've got an unstable patient with significant hemiperitoneum and you're concerned about the possibility of an ectopic pregnancy that's either ruptured or a tubal miscarriage. In those situations, clearly, you might not have fully visualized the ectopic pregnancy, but it would be appropriate to take that patient to theatre and perform a laparoscopy.
Yes, so you're saying that we should not go for laparoscopy patient stable, no hemiperitoneum. If we should not go for laparoscopy unless we know what we are going to do, unless we know what we're going to operate. So, and of course, unstable patients, this is another category of the patients, but for those that are stable patients, we shouldn't go for it.
Absolutely. And of course, surgery may not be your first line management anyway. All those things that we discussed in the meeting regarding, looking at patient factors, the morphology of the ectopic pregnancy, symptoms, and of course, the serum beta HCG level. But the key message is really certainty of diagnosis. There was a good question in the chat from the audience regarding if you did do a laparoscopy in someone with significant hemiperitoneum, what would you do if the tubes look normal? And this is a really common scenario, by the way, clinically. And I guess that the answer to you would be, it depends. If that was that patient's first ectopic, they're young, and the tubes really look normal, and you felt that possibly this had been a tubal miscarriage, and the ectopic pregnancy tissue is sitting in the pouch of Douglas or in the abdomen with some blood and clots, the tube has stopped bleeding, everything seems okay, you can milk the fallopian tube and then ensure not do a self-injectomy in that circumstance and potentially monitor the patient with serial beta HCG levels. But clearly, you need to be able to arrange the follow-up. You need to be able to have a patient who will comply because there is still a small risk of persistent trophoblast if you don't proceed with the self-injectomy. So it really depends on the clinical scenario, but I don't think you necessarily, in the case of a tubal miscarriage, have to commit to doing the self-injectomy.
No. And in case that you decide to leave the tube, you said you would follow with ECG, which is mandatory, but when would you take ECG and how would you know that it is not persisting trophoblast in the tube left? How would you know that? How come?
So often what I would do is we'd have had the HCG probably on the day or around the time of surgery. I'd normally repeat it a few days later. If it's dropped, I'd see the patient weekly until it's dropped completely altogether. Most of the time in this case, if really the tube is normal, it will resolve. It's very rare to need to do a secondary intervention.
Maya, let's move to medical treatment. We have some questions about the mifepristone role in ectopic pregnancy.
Yes. Really good question. And I would say really difficult because mifepristone, I think the question asked about PUL as well, but there is no clinical management of PULs, meaning we are not intervening. PULs should not be managed surgically, medically, or in any way. PUL is a transitional term where we can't see a pregnancy and then we need to manage it in according to triage based on HCG and progesterone levels. And based on triage, we can then categorize patients as low risk or high risk. And if they're high risk of ectopic, try and allocate our resources and energies into those patients who might have a missed ectopic pregnancy. Now, in the case of mifepristone for ectopics, I think there is some data in the literature out there, but we don't have the really good quality proper studies, randomized studies, to really be able to incorporate that yet into clinical practice.
Okay. Thank you, Maya. I think while we move to Ilan, and there are so many questions because cesarean pregnancies are so important, and of course there are many controversies about the classification and about the management, and you have highlighted all the main points on the management. But I think we let's start with two questions first. So the first one is, when you do the measurements of myometrial thickness, of the remaining myometrial thickness, how do you measure? So first, do you measure from the gestational sac, or do you include the trophoblast in the measurement?
Okay, so I think that the measurement really is extremely important. And I wrote a whole article about the technique of how to measure the residual myometrial thickness. And it should be measured first of all, to leave out the hyperechoic mucosa of the bladder. You should always have a little bit of urine in order to exactly know where the boundaries are. And the lower point of the measurement is really the area of the gestational sac. Now, if the placenta is there, then you measure, of course, from the lower point of the mucosa to the closest point of the placenta. Basically, you can see if there is myometrium, you can see where it is. It's a different grayscale appearance of the myometrium, and you can I presented one of my slides was exactly that. It was an enlarged lower segment with the internal os, external os, and a little bit of the bladder. Extremely important to measure it correctly and not to include the echoic mucosa of the bladder.
So the next question is about the different management for on-scar cesarean, on-scar pregnancies and ectopic pregnancies. And you read here in the chat that you will discuss the management. So what is the difference in the management?
So basically the first of all, is I think it's important to determine which is it, type 1 or type 2. And here I interject the thing that I discourage to be on the fence and do, it's not really less than 3 millimeters, it's not more than 3 millimeters, it's somewhere in the middle, because then you will say, okay, it can be good outcome, it can be bad outcome. The patient should decide what she wants to do with the pregnancy. And then when the pregnancy is done and it's a good outcome, then the practitioner say, oh, I told you so. It is, I mentioned it will be good, probably. And if it's a bad outcome, then you say, oh, I said that it would be also bad outcome. So make up your mind and be precise and say, it's type 1, it is probably a good outcome. And we had one article that I quoted by Kaylin Acton. Today I quoted it, and she was my fellow for 3 years in New York, and we wrote the article together. We had 17 patients, and in 11 patients where the RMT was lower than 3 millimeters, all had hysterectomy. In 6 patients in which the RMT was more than 2 millimeters, 3 or more, only one had a hysterectomy, and that was done for obstetrical reasons, not for being a placenta accreta spectrum. So that is my answer because that's really supported in the literature. And I also pointed out in my lecture that there are so many classification systems, and I still have to find external validation for more of them. And the reason is very simple. Take the Chinese one that has about 6 or 7 kinds of classifications until you will find so many for each of them, and then statistically make sense of it, and get a good percentage of outcome. It will take 20 years because scar pregnancy is rare. So I think be practical, be patient oriented, type 1, type 2. And again, it is a valid um, academic discussion, and I hold that there are two types, and that's what I think it should be. Now, if you want to terminate a pregnancy, I usually try to do it as soon as possible, and I always tell the patients, come back with your decision in about 24 hours. Why? Two reasons. One, the pregnancy is growing fast at that time, and the vascularity of that pregnancy increases. And that's also one of the answers. While somebody asked whether you see a difference in vascularization. Yes, you do see an increase. Therefore, I want the patient to decide. And the procedure to terminate is much easier when it's done earlier than later. And I hope that you concur with this statement of mine.
So it's good explanation. So let's say like completely in practice. So if we have with a type 2 pregnancy, because type 1 pregnancy time free, but if we have a type 2 pregnancy, uh, how should we choose the appropriate management? How should we what do we need to look at? How can ultrasound guide us? Is it something we need to look at the implantation side? Do we need to look at the at the at the risk of the patient? How do we have to be? Where comes the ultrasound in that?
It depends upon the gestational age primarily. And I had in previous Isuog sponsored courses, we had discussions with Davor Jurkovic about this. And most of it I lost with Davor because he basically says DNC. And I agree, but that is up to 8 weeks. If you do it, you probably should do my way to do it is the following: do the DNC under ultrasound guidance, and immediately put in a balloon catheter. I use the double cervical ripening balloon because it can obliterate many more areas in the uterine cavity than a simple Foley catheter. There are two sizes of Foley catheter, Foley balloon catheters, and I use the bigger one if I need. I leave it there for 24, sometimes 2 days, and that the reason is that time is taken for the blood vessel to coagulate. And then I gradually take it out. I deflate it first, wait an hour, then I pull it out, wait another hour, and see whether she bleeds. If she bleeds, I or re-inflate it if it's still inside, or put it back if I already took it out. And the patient can go home. She doesn't have to be in the hospital. She can take a shower. Everything is fine. And I had great success doing that. I don't know whether Davor is inserting a balloon after it or not. He probably is more confident upon his DNC. He's the master of treating scar pregnancies, and I trust his decision. I think that I answered this one. So gestational age is important. Later on, there are several other things. Again, It could be just the balloon, first of all, in order to terminate the heartbeats. And number two, maybe also minimize blood flow. And I always give methotrexate intramuscularly because it's a placenta that's working, and I fight the HCG production by the methotrexate. I think there was another question whether I take into consideration the HCG level. I think HCG level really parallels the size and the gestational age of the pregnancy. So I look at it, but I think for me the size and the gestational age is more predictive than the HCG.
So great. So is there a role for methotrexate treatment solely?
Say that again.
Do you treat scar pregnancies with only methotrexate without evacuation?
Okay, I brought up this issue in one of my slides when I said that um, some think that it's an ectopic pregnancy and use the same treatment as for like a tubal pregnancy. And in one case, that led to mortality in the United States. So I think that basically you use methotrexate as an adjunct, not as the main treatment, and keep that patient under supervision completely for the next couple of days, not in the hospital, but at least a rescan every 2 days to see what's going on.
Okay. So I think we give you one more question here. Just if you decide, if we need to repeat ultrasound scans to monitor the growth or the progress of the scar pregnancies, let's say type 1, would you do it weekly? How often would you monitor them? It's very practical. I think very practical questions because, of course, we need to know how we do this in practice. So what is your way? How do you do like in your clinical practice?
Well, I will be honest. I don't think there is any article that meaningfully dissects this question. Um, my own practice, definitely weekly, and depending upon the patient's clinical status, is she bleeding, spotting? If she's bleeding or spotting, I bring her back more often. And again, how do I define? How do I say? Spotting is if you have one pad a day and they have a little blood on it. Bleeding, 2, 3 pads a day, or and hemorrhage, if it's soaked or the blood runs down your thigh. If the blood runs through, that's a hemorrhage. I keep these patients then in the hospital and maybe select a secondary treatment. And again, secondary treatment is the way that sometimes we have to deal with our own failures of correctly predicting what's going on, or if we predicted, but the course changes, and we are prisoners of our consulting, and we have to be responsible of what we say.
Great. Thank you so much, Ilan. We have many, many more questions, but I think I see very important question. And Maya, I think you can answer it or we can just bring it to discussion. So if we do, it's about the PUL and you have a PUL, you do not see any pregnancy intrauterine or extrauterine, and then you take a beta HCG level and it's more than 1,500. The question is, if you have more than 1,500 level of beta HCG, and you do not see intrauterine gestational sac by vaginal ultrasound, would you give methotrexate?
Absolutely not. This is really, really important. So we have to move away from gestational cutoffs, HCG cutoff values. If you had this situation where you had done a good transvaginal ultrasound scan and you were unable to locate a pregnancy, be it utopic, intrauterine, or extrauterine, then this is classified as a pregnancy of unknown location. I would not offer treatment on the basis of a single HCG level. And what we would do is classify them as a PUL and treat them in accordance to the PUL model. There's a widely published model called the M4 or M6 model. This is validated in use in the triage of PUL. There was another question, but just to be clear, not used in the treatment of ectopics. It is used in the triage of PULs. And if you can apply that model, what that means is essentially you take a beta HCG and progesterone on the day of the scan. If the progesterone is less than 2, that patient would be considered low risk and then discharged and offered a urine pregnancy test in 2 weeks, as it is most likely a failing pregnancy. If the progesterone is greater than 2, you would repeat the HCG in 48 hours and look at the trend. In women then classified as high risk of ectopic, you'd be offering them a visit back to see you within 48 hours for a repeat ultrasound scan and, if needed, a repeat HCG. At that scan, it's very possible that you'll then diagnose an ectopic pregnancy, but it's also very possible that you might then see a little intrauterine pregnancy. So there is no rush. And there was a very good question about, in my experience, what the most common pitfall. And I would say it's 2 things: misdiagnosis and too early an intervention. In early pregnancy, you often do no harm just by watching and waiting and seeing the patient again in 48 hours. You can do far more harm by treating immediately or giving methotrexate or intervening just too soon. So in a stable patient, just wait, do the hormone levels and see them again. That would be my message.
But tell us, Maya, where can people get the models? How can they get access to M4 and M6? We're talking about these are very good models. Yes, I think but the access, where to get them?
This is very, very difficult. And there used to be an app and everything accessible. But I would like to say that things are changing. The reason the access went away is because of changes in criteria. These were then classified as medical equipment, and they had to undergo quite different checks and balances in Europe. And so that's why they were removed, a bit like IOTA Adnex. But the team have worked very, very hard in trying to reinstill these so that they are available for everybody to be used. So hopefully, the access to these models will be made available more widely again, all over again. And we've passed this very dark time over the last few years.
Yes. Good. I see one question about how to differentiate between cervical ectopic or an ongoing abortion. And I think I can take this question.
Yes.
Yeah, you can also welcome to comment. Of course, you look at the location of the pregnancy, you look at the implantation, you can use a Doppler and see if you see any implantation site in the cervix, and also what helps you when you push with the probe um, towards the cervix, you will see if there is a ongoing miscarriage, the pregnancy will be gliding against the cervix. So you will see a movement between the cervix layer and the pregnancy. And if it's implanted there, then of course it stays there. And of course, heart activity may also help, but we have some ongoing miscarriages that we can still have heart activity present. But I think the implantation site you have to look at and to look for the Doppler information and also for the movement. I don't know, May, if you have anything to add to it. How do you do?
No, that's perfect. There was a good question about Doppler use in the diagnosis of ectopics. And I would say in tubal ectopics, it's an adjunct, but not necessarily useful diagnostically. But for all the less common ectopics, like cervical, the scar pregnancies, of course, the interstitials, cervical, Doppler can be your friend and really, really helpful to guide you as to the implantation.
So I think, unfortunately, the time is out. And it was really a great webinar. We have enjoyed it a lot. And I want to thank, first, I want to thank all the speakers and the faculty who have prepared the lectures and shared their knowledge, and also shared their knowledge, practical knowledge during discussion. Yes, and I would like also to thank our participants, those that are interested in the topic, and the staff that has made this webinar possible. And lastly, I would like to thank again our sponsor, Samsung, for supporting this webinar and making it possible to happen. So for those that want to know more about early pregnancy complications, we are going to run an ESO course in January, on the 17th of January, which will be run as a hybrid course on site in London and also online as we meet here in form of live stream course. So you're welcome to join either live or on live streaming. And of course, all the courses that we run are available for 2 months after that on demand. So you can get access to it even if you are not able to attend that particular day. And if you want to know more about the placenta pathology, we're going also to run a course next year in April. We will cover also cesarean pregnancies and also placenta pathology during later pregnancy trimesters. So again, that one will be delivered only as online course, but you are very welcome to attend and of course to know more about it. All this information you can find on Isuog webpage together with other webinars that we are having coming months. We're going to have a webinar on the pediatric gynecology, which also for free, and one also webinar in gynecology, how to get the best image in gynecology, which will be also run in the summer. So you are very welcome to attend, and we hope to see you soon again at our next events. Thank you very much.